Hi, this is Dan Limmer. We're here with the Brady Educator podcast, and I'm here with my good friend Joe Mistovich. And today's topic is teaching pathophysiology. We're going to do an introduction. The education standards have introduced pathophysiology into EMS education. Where that really makes a difference is in EMT education. So today we're going to talk about just the basics, an entry level. What is pathophysiology? How does it fit into the EMT curriculum? And just some of those core concepts. For introductions, my name is Dan Limmer. I have the good fortune to be an author of the Emergency Care EMT textbook and several other textbooks for Brady. And I've been involved in EMS for 33 years as a practitioner and educator. And I'm happy to be here today to give you this information. And Joe.
I'm Joe Mistovich. I'm the author of Pre-Hospital Emergency Care. And like Dan, I've been in EMS for 33 years also as a practitioner and also as an EMS educator. And actually, this is my 27th year at the university teaching EMS. And been involved with this National EMS Education Standards Project too.
Well, we'll roll right into pathophysiology. And perhaps the big question is why? What was the intent of the education standards and putting pathophysiology in? And I'll hand this to you, Joe, because I think you are very, very passionate about this and have really always taught pathophysiology, and I think that'd be a good perspective to start from.
One thing that I've always done at the university, even with the EMT courses, and I think as you alluded to it a little bit, that the biggest impact I think we're going to see with the pathophysiology is at the EMT level. We've been teaching paramedics for years pathophysiology, but now we decided that EMTs need to be thinking EMTs. We have moved away from the old DOT curriculum where EMT was just a reactionary individual. You see this, do this. Basically, what they were doing is putting oxygen on patients, taking them to the hospital. Realizing now the change in the science, we have to make decisions on things as simple as oxygen therapy, where oxygen therapy has not become as simple as we thought it was. O2 hurts some people. And so EMTs no longer can just make knee-jerk reactions, put a non-rebreather on the patient, and take them to the hospital. They have to make some clinical decisions, even about oxygen therapy. And in order to make those decisions, they have to have a foundation of knowledge. As part of the education standards group responsible for writing those standards, I pushed for pathophysiology at the EMT level. And what's interesting, we keep calling it pathophysiology, but really what we're teaching EMTs is normal physiology so they can recognize the abnormalities. And so sometimes it sounds deceiving that we keep calling it pathophysiology. I think what we're teaching them is normal physiology so they can recognize the pathophysiology. And what it comes down to is their ability to understand. One thing I always preach to students is do not memorize. Do not memorize sets of signs and symptoms, because what happens is you memorize those for an exam, 2 weeks later, you completely forget them. And so by understanding some of this basic physiology, understanding the pathophysiology, students they don't have to memorize anything. They basically understand. They can explain to you why something's happening.
And as an educator, if you're looking at having your students memorize a list of signs and symptoms of shock or understand why they're there, it's so much better education. And I'm not really sure it is that much more to do in the time, but it certainly does appear a very daunting task.
It does. And I think one thing that we both agree with, and I know we've discussed this at length, we've talked about it in front of EMT audiences, we've talked about it to educators and so forth, but the pathophysiology cannot be taught as a block and then forgotten about. If you look at a typical EMT class today, a lot of times anatomy and physiology is taught, and then it's, okay, we're done with this section and let's move on. It's almost like medical legal. Let's teach medical legal, then we're done with it and let's move on, and we're never really going to come back to it and talk about it again. The difference with this approach to the pathophysiology is it has to be integrated throughout the entire program. Anytime you're talking about a clinical topic, no matter what it is, the diabetic patient, the patient with acute coronary syndrome, the shock patient, the OB patient, that pathophysiology has to be continuously integrated into that lecture material. So when you say, well, here's my pregnant patient and the blood pressure, or in the pregnant patient who's in shock, why isn't the blood pressure falling, when this patient's 24 weeks gestation, where in the non-pregnant patient, the blood pressure is falling? And if the student understands that real basic physiology and pathophysiology, they'll be able to explain that. And I think what you find is they shock themselves actually by understanding. And so then all this starts making sense to them. As simple as you say your anaphylactic patient has warm, flushed skin. Why? And the student should be able to go back to some of this basic information and say, well, wait a minute now. Well, the vessels have to be dilating if the skin is warm, red, and flushed. And so therefore it's these real basic principles. And then you start saying, well, then obviously you understand a piece of the pathophys, because in anaphylaxis, the vessels dilate. And so all of a sudden you start putting this all together with this basic foundation of information.
Well, while we're talking then about those types of things, let's talk about exactly what is included in the education standards, because I think there is some misconception. And the other thing I'll say is that when we're talking, we're largely talking about the EMT standards, because paramedic really hasn't changed all that much. The big difference here we're seeing is with EMT across all the levels. This is the biggest difference. So while we're focusing on that, obviously the standards affect all the levels. The standards basically talk about ventilation and perfusion. That's the pathophysiology there. We're not talking about the detailed pathophysiology of acute coronary syndrome or things like that. It's really about ventilation and shock, which of course works through many of the things that we do.
I think one of the things also, and just to add something, not only at the EMT level, I think also the old I-85 or 85 curriculum, advanced EMT, because they basically were EMTs, provided some more information on shock and IV therapy. So that group too, the I-99 intermediate, has a lot more information. But I do agree with you, Dan, that it is at the basic level, at the EMT level, and also at the advanced EMT level, from the old advanced EMTs moving up to the new education standards. This does deal primarily with issues with ventilation, issues with oxygenation, and issues with perfusion. But right away when we say perfusion, a lot of people think, shock. But the perfusion is perfusion that's related to every condition pretty much that we can think of. One thing I always say is, everything that we do in EMS for our patient in our treatment really revolves around pretty much getting oxygen and glucose to the cell.
I just stopped for 1 second. I'm not sure if people that were listening can hear the sirens outside. Right. We're doing this. It's just a theme that we've added here for this.
A nice touch to the podcast.
It was on purpose, totally.
But I think, and that's what this pathophysiology section really is revolving around: understanding the issues in interruption of the delivery of oxygen and glucose to the cell. Because if we don't continue doing that, we start altering the cell metabolism. And when we do that, we start seeing cellular dysfunction, tissue dysfunction, organ dysfunction, and so forth. And one thing that is so important to point out, as you already said, we're not interested in teaching students the pathophysiology of some hematologic condition and some of these, really involved conditions and so forth. That's not what this is about. This is getting the EMT student to really understand the basic concepts of how do we continue to deliver oxygen and glucose to cells. And again, as I already said, everything we do, you open the airway, you stop the bleeding, you give glucose, you ventilate the patient, you put the patient on oxygen. The bottom line to that is continue to get oxygen and glucose to the cell.
I'm going to ask you, just to keep going, because you and I have presented on this quite a bit around the country, and I've heard you talk about this. And even one thing at a recent conference we attended, you had talked about the patient that was not breathing well and was kind of sleepy looking in his appearance, and you related to the class how that pathophysiology played in and how the student would better understand that. I think that'd be just something really great to talk about just for a second now.
I think what I did is related it back to basic cellular metabolism. And it's interesting to watch the audience, and they start catching on to this, and they start thinking, well, I really could apply, believe it or not, Krebs cycle to my clinical assessment. And so we talk about basic metabolism in the cell. We talk about aerobic metabolism, and we talk about anaerobic metabolism. We go to really at a basic level, and we say, okay, in aerobic metabolism, you had to have glucose getting into the cell. When the glucose gets into the cell, it starts producing a little bit of energy initially, just 2 molecules of ATP. But when you add oxygen, it gets in through, into the Krebs cycle. And the end product is you get a lot of energy, you get heat, you get oxygen, you get carbon dioxide. I'm sorry, you get water, not oxygen. You get heat, carbon dioxide, a lot of energy, and you get water. And you say, okay, what do we do with water? Well, the body reabsorbs water. Water is a good thing. The CO2, very easy to get rid of. You breathe it off. As long as your patient has a good airway, good ventilation, and good gas exchange, it's easy for them to get rid of the CO2. The heat, it's necessary for normal enzyme reactions. We have to have heat. And then the energy is necessary for the cell function. If you don't have energy, the cell's not going to function. Something as simple as you want your cell to dilate. And I know an example I use over and over and over is, so you have an EMT who gives a meter dose inhaler to a patient having an asthma attack. Well, if that patient's bronchial smooth muscle doesn't have enough energy to change its structure and function, it's not going to dilate even with the bronchodilator. So you have to have that ATP, you have to have that energy. And that's a big key, and that's something that you can look for. So the analogy that I use, or I guess the example that I use, is in anaerobic metabolism, when the patient is not getting an adequate amount of oxygen to the cells, what happens then is they're shifting this metabolism from this oxygen environment, this environment where they have the oxygen being delivered to the cells, to this cellular metabolism where they don't have an adequate amount of oxygen. Glucose goes into the cell. They're still producing very little energy, but 2 molecules of ATP. But all of a sudden, they can't get into the normal Krebs cycle because the oxygen is not available. So what do they produce? They produce a lot of acid, lactic acid. So the key there is when you have oxygen getting to the cell, the patient has lots of energy for normal cellular function. When you have anaerobic metabolism, where you're not getting adequate amounts of oxygen to the cell, like in a case of poor perfusion, the patient has very little energy. So the example I use is you have a car crash, a driver vehicle, a passenger of a vehicle. You arrive on the scene. The driver of the vehicle is screaming, yelling. He has a open fracture to the humerus that's sticking out at a right angle. He's grabbing at you. He's pulling at you. He's yelling, help me, help me. And most EMTs, especially the newer EMTs, will be drawn into the dramatics, go to that patient. But yet the passenger of the vehicle is sitting there, not saying much, looking straight ahead. You go to the driver, screaming, yelling. You go to the passenger. You ask how he's doing. He says, okay. Calmly, quietly, okay. And I said, which patient is worse? And after having that basic metabolism lecture, the EMTs recognized that the guy in the passenger seat has very little energy. And one of the reasons why he may have very little energy is because he doesn't have adequate perfusion. And if he's not getting the oxygen to the cells, he's not producing the ATP, which translates into very little energy. The guy who's screaming, if he's screaming, yelling, pulling at you, he has a lot of energy. So what that means is he probably has a lot of O2 getting to his cells. And the students just start clicking then, and they start recognizing that I can apply this clinically. And really, this does make sense. You always get those students who come and go, well, I learned this in 10th grade in biology class and never thought I would want to ever talk about this again, never understood it. And you know yourself, Dan, we just did a presentation yesterday with a gentleman, older gentleman, probably in his early 60s, who said, I never understood this, but boy, does this now make sense.
Well, let's go back to a broader scope then. That we've pretty much said, and I think that was a great example, just for the educators to to hear about how this works, how to explain it in class, what the reality of it is, what the functionality of teaching pathophysiology would be. But there certainly will be challenges as well. The fact that we're adding pathophysiology in, especially in ventilation and perfusion, means that it's woven throughout the curriculum. If we were to take and just change a couple modules, add in a couple new skills, there really would be no major problem. But the fact is that through the beginning of the course, when I think a lot of people will teach an initial pathophysiology segment, then going through airway, which we've talked about is probably one of the biggest problem areas on the National Registry exam, and I think this certainly could help that, then going through into some of the medical conditions, and then getting into shock and perfusion and trauma. This is woven throughout the standards. It's going to be woven throughout the EMT course, and it makes the challenge much more difficult for the educator. Anything what I teach is that I think that you have to explain it understandably, and I think you have to make it relevant. I think those are really the keys to making the pathophysiology go with the student. Certainly a good explanation, making it understandable, but if you can create that aha moment where the student's going to picture the patient and really know why they learned it, and quite frankly, having an educator who is able to say, this is why I'm teaching it and feel it click is really important.
Oh, absolutely. And I think one of the challenges right now is that the EMT educator has to be much more prepared and understand the pathophys at a deeper level than what's going to be taught to the EMT student. So the EMT educator has to do some homework here. And as you're saying, so when the question comes up or when you're doing the explanations, they have a deeper, more depth and breadth of understanding of the information than what they're presenting to the student. And it's fascinating to lecture to students. And when you're presenting this and they're sitting there and you pose these questions to them, and they figure this out on their own, and they're looking at you with that aha moment. There's no better feeling as an educator to look at their faces as they're sitting there going, I can't believe I just figured this out. But they figured it out with some really basic information. And I think you're absolutely right. That's the point you want to get the students to. And so when you're posing, what's interesting is what I find with EMT students, and you provide them with this basic information. And as you said, Dan, you have to integrate this into your lectures. I find students not wanting me to tell them the signs, the symptoms. They want me to tell them, well, in this condition, you're going to get vasodilation. Let's say a spinal cord injured patient. Well, what's happening in the spinal cord injured patient? Well, you might get vasodilation. They don't want me now to stand there and tell them the signs and symptoms. They want to tell me the signs and symptoms based on what they learned in this basic pathophysiology. But the students coming into the EMT classes, they don't know. They haven't been exposed to this before. It's the EMS educators that are the ones that have to actually present this in a way where the students are buying in, present this in a way where the students are actually being challenged to understand this, challenged to use it, and most importantly, here's the important part, challenged to apply it clinically. If the instructor doesn't apply this clinically, then you know what? You should probably teach it in a 1 week module and forget about it because it's not being integrated. And I think that's when you're saying it has to be integrated, it has to be integrated, it has to be integrated. I think both of us are agreeing that it has to be integrated throughout the entire clinical topics in your curriculum, but at the same time, apply it clinically. And again, that very simple example of the driver and the passenger, that's a clinical application. It makes a difference. And you're thinking to yourself when you're approaching the scene, and you're not thinking Krebs cycle, but what you're thinking is, this guy doesn't have enough energy. And that may be because he has poor perfusion. You haven't taken a blood pressure, you haven't taken a pulse, you haven't touched the skin, but that's in your mind. So it really does improve assessment ability and assessment skills.
Really, throughout your course, this is going to be a difference. And the word that I want to use in listening to what you said is almost a cultural change. That you're not just changing a lecture and switching out some information. And you've been doing this for a while. You've been doing this in your classes even before, so it certainly can be done, even in reasonable time frames, I think. But really, this is a cultural change for an educator who's been teaching a pretty straightforward EMTB course. It is going to be a change. My prediction is that a lot of the courses that are taught when we first switch to the education standards are largely going to be closer to the EMTB course than they're going to be the EMT course. And that's going to take a little bit of time to get that change across and make it happen. But as we look at the changes, one of the things I found from educators is that they have trouble visualizing what the course is going to look like in doing this. One of the things that came up in a rollout that I was doing is that the beginning of the course really has changed a little bit. If you use follow the chapter order of your books, which many times follows some of the concepts of the standards, we've significantly expanded what would have been the introductory material when compared to EMTB. When you take the beginning of the course, which was traditionally Introduction to EMS, Well-Being, medical, legal, and ethical, and then anatomy and physiology. The education standards, if in a classic grouping, how we might see this class done, we've added medical terminology, lifespan development, pathophysiology, and anything else that you want to put in the beginning of the course. It could be argued that we've almost doubled the amount of the material in that front part of the course, and one of the concerns that came up is that it changes the character. What was the cadence of the old EMT course? The cadence was you go through this early stuff, it's kind of easy, you have a couple easy quizzes, then you get into airway, then you get into patient assessment, and we quickly get into the good stuff, the stuff where we have lab stations and work on patients, and then medical and trauma. Now we've put some pretty significant science, some higher level reading stuff in the beginning of the course. We've probably extended the course. Now, I think most everyone will teach some initial pathophysiology, but it's really up to the educator whether you teach a lot of it up front or you teach some up front and then really hit it hard again in the individual, the lessons that you're teaching. But one of the things that came out is that we've changed character and we've changed culture. And that while this is going to be a challenge, it certainly is an opportunity. But this is not a simple change. I'm not trying to make this scary. I'm not trying to make this a bad thing. But more has changed than simply adding content. That we're really talking about significant and some high level changes to concept and not just content.
Yeah, and I couldn't agree more. And I tell you, this is an exciting time in EMS, and I look at this and I say, we've both been in EMS for a long time, and we've seen EMS evolve. You look at other allied health professions, and we've evolved so fast in EMS, and I'd have to say at this point now that I couldn't be prouder of our profession that we're now relying on science to provide us with direction. And it's interesting because then you say, okay, well, that's great. These researchers go out and they do these studies and they find this and they tell us we can do this, we can't do this, whatever it would be. But Dan, we take something like ventilation and we say, okay, let's take, in the past, this as well as I do, and ask only any older EMT, older paramedic and say, in the old days, well, what do we do to cardiac arrest patients? We try to ventilate them 60 times a minute. If we came into the hospital and their arterial oxygen levels were 600, we were high-fiving each other.
And we did have those.
We did. And we took pride in aggressively ventilating these patients. Today, we probably would have the EMT in the supervisor's office, and the medical director there if the EMT ventilated the patient 60 times a minute. But I think exactly what you're saying is for now the educator to present this to the EMT student, and they say, well, in a cardiac arrest, the max you can ventilate at is 10 to 12 times per minute. Then what happens is you send your EMT out on the squad to ride, and the old timer's sitting there going, more O2 is good, more ventilation's good. I still ventilate at 40 times a minute. This confusion drives these students nuts because they come back and they say, well, Dan, you told me 10 to 12, but this guy's been out in the field for 25 years and saying more O2 is good. I need to ventilate him more. The educator has to have the ability to explain to the student why 10 to 12 is the right ventilation rate, how the patient is going to get hurt, how they're going to be affected by overventilating. But better yet, the student has to have the foundation of knowledge to be able to understand your explanation, but they should be going in the field already with that knowledge. And this is all part of this pathophysiology. For you to step back and explain to the student why that overventilation is bad with this foundation to be able to understand it. Without the foundation, you know what they're probably going to do? They're probably going to go with the old guy's doing and say, well, he's been out there for so long, I'm going to follow what he does. And so what it does is as the science changes, one thing I always tell my students is, you guys, what I'm teaching you today may be different in 3 months from now. Follow the science. Just because I'm teaching it to you today, it may change. You need to follow the science. But in order to follow the science, you have to understand it. And we're not saying you have to have a PhD in, physiology but if you understand some of these basic concepts, you'll be able to figure out what's happening and why things are changing. And you buy into it. And the bottom line is, you do the right thing for the patient. Science changes because they want to treat the patients right. And I know we both advocate you always have to do the right thing for the patient.
We're going to be doing some additional podcasts to help educators teach pathophysiology. We'll specifically do podcasts on the airway and ventilation, and we'll do one on perfusion to help educators. But broad scope, what what should an educator do to prepare for this? Because I mean, anytime we went to a rollout when these education standards came out, the statement was some educators are going to be left by the side of the road. We're going to leave people by the side of the road who aren't going to be able to teach this. So for the people that are staying in the game, and I believe that'll be a majority of people, how would you advise an educator to prepare for this? We'll work on the actual preparation in a subsequent podcast, but an educator saying, all right, my standards course is, well, might be going on now. Anyone taking the registry after January 2012 will have the new standards, although I don't believe it'll be a dramatically different exam. We've talked about that initially, but how would an educator prepare to teach the pathophys?
It's interesting because Bill Brown and I have done these teaching pathophysiology lectures at the National EMS Educators Conference. And it's interesting that we have a lot of paramedics and we have a lot of nurses that actually sit in these in the one-day pre-conference. And one thing Bill always says is, well, if you're a paramedic or nurse, you really shouldn't be in here because you should already have this foundation. But it's interesting how many of them actually sit through the whole 8-hour presentation and they walk away saying, there are a lot of things I didn't know, and there are a lot of things that were reinforced to me again, and I have a much better understanding. So I think that even for the paramedics who are EMT educators, they're going to need to go back. They're going to need to refresh. They're going to need to take a different look at things, because I think the key again here is you have to be able to apply this to what the EMT student needs to know to make good clinical decisions. So apply it clinically. And so in order to do that, you have to go back to the books. You have to go back. Like, even, we talk about aerobic and anaerobic metabolism. You might have to go back to a basic biology book and just read about it so you have an understanding. Now, you're not going to take that biology book, take it into class, and teach what you read out of that entire chapter on aerobic and anaerobic metabolism. You're going to summarize it and apply it clinically, but you'll have a much better understanding. I would say get back to the books. I mean, our EMT transition book is actually a great resource. And we cover all of the pathophys. We cover it in chunks of material. I think that the instructor can go back and read. And here's the thing, Dan, if you read something in that transition book and you say, this still doesn't quite make sense to me, go back to the more books with more depth and breadth, the biology books, the pathophys books. Get online, search some sources. Just be careful what you're searching. Make sure it's a reputable site. Go to lectures, attend lectures. We're often doing things on teaching the new standards and so forth. There are resources out there. But I think the main thing is the educator has to take the initiative to understand this. And when they take that initiative and they understand the material, then they're going to be a much better educator at presenting this material to the students.
I think that it's true. People will certainly have to hit the books, and I believe people will also, after they teach a class or two, will really start to hit their stride. I don't think anybody's really going to expect perfection the first time we have to do it. And I think I'll wrap with a thought that I also told at a recent rollout, is that I think it's important for educators not to go into class and keep continually talking about the new education standards and how things are different. When a student comes into your class, they're coming into their EMT class. It's not a basic class or an EMT. They're coming into the class that they signed up for. And I think that it's time for us to shed some of the baggage, psychologically change. It's going to be very, very different and traumatic for us. We believe the courses are going to be a little bit longer, a little bit more depth. I think there'll be a little challenge reading some of the material. We know there'll be challenges there, but let's not bring that to the students. I think it's important to keep a good face forward in this to present it to your students, and resist the ability to say, this new EMT stuff, because we did it when we went from EMTA to EMTB. We said, this new stuff, and we complain about it and we do it. And the fact is, this is what we have. This is what EMT education is about. I do believe it's a maturation process that we have moved forward, and I totally agree with you, at a pace faster than many allied health professions have over the years. But when we do it, the change is much more traumatic to us than it is to the students because they're coming in for EMT class.
And I couldn't agree more. And I mentioned even earlier that the students don't know. They don't know. If you walked in and you're positive and you're presenting this information and you're explaining it, the student doesn't know that this is different than the EMT student who was in your class 2 or 3 years ago. Yeah, I couldn't agree more. And I'll leave with this thought. It all makes sense. And you can take things that seem very difficult and break them down to a basic level with some basic understanding of this pathophysiology and normal physiology and normal anatomy, and you can make this really make sense to the students. We're here again, they're not memorizing signs and symptoms. They're not memorizing, these conditions and so forth, but they're understanding them. It all makes sense.
It does. So let's wrap this introduction to teaching the new education standards and pathophysiology up now. I think that many instructors are at a crossroads now, and we're looking at this as a problem or an opportunity, or sometimes both, and that me, Dan Limmer, and Joe Mistovich are going to be recording some podcasts that are going to help you integrate this into your EMT class and hopefully gain the benefit that we believe is there of that understanding. And as Joe says, having this all make sense to create some better thinking and functioning EMTs. Thank you.